Good afternoon, everyone. It's the bottom of the hour, and we are going to begin. I ask you to mute yourself until the end of the presentation when we'll have open discussion. This is the Florida Medical Directors Association Journal Club. The date is February 19th, 2020, and I am Dr. Diane Sanders-Cepeda, and I will be presenting a topic that you've probably seen in a lot of our newsletters, journals that have come out either in the Journal of American Geriatric Society or in the Journal of the American Medical Directors Association. And now we're seeing it even in other journals like New England Journal of Medicine, Annuals of Internal Medicine. The topic is deprescribing. And it is something that I would say has been a topic that, at least in the geriatric community, we've been discussing for a very long time. I don't know about any of you, but this was one of the first things that I remember having a conversation about when I entered into geriatric fellowship. And we did call it deprescribing, that it was polypharmacy and inappropriate medication, elimination, discontinuing meds, all of that, but it's still sort of that same idea and conversation that we are having now. And I titled this presentation, The Myths, the Art of the Science, because if you had the pleasure of reading through the articles, you'll see that there's still a lot of uncertainty about how to proceed with deprescribing. So in the sake of time, I'm going to jump right in. And the first article comes from the Journal of American Geriatric Society. It is a little bit older, but I thought it was still relevant to the conversation. It's titled Older Adults Awareness of Deprescribing, Population-Based Survey. It is from Dr. Turner and group out of Canada. So, that's the first thing. We know that Canada is a lot different than the United States in many ways. So it was interesting that they were able to get so many individuals surveyed, and I appreciate all the great research that comes out of there. Once again, if you're not speaking, please put yourself on mute. So the purpose of this study was to determine older adults' awareness of medication-induced harm and the familiarity with the term deprescribing. Now, as I was reading through this article, I must say I was reminded of all the occasions where someone brought in the package insert in the medication. So I don't know if that is an experience that they're familiar with in Canada, but I think, many of us have had these conversations with our patients as they're going through all the side effects listed for the medication you may have prescribed. When they looked at who, when they were surveying individuals, and this was a telephonic survey, they went through, and there were some unique characteristics about the population. Majority of those surveyed were under the age of 80. Many more females than males, and this is Canada, so we did see a large French population, although the majority spoke English. There were, the majority of those individuals surveyed were on between 1 to 4 medications. What they did in this study was they asked some very interesting questions. They asked, are you aware of harmful medications? And are you aware of deprescribing? Now, like I said, the word deprescribing is something that we've been utilizing in our conversations in academic circles and amongst our societies for the past several years, but it's not something that you may hear about in everyday common language. So they ask these questions, and then they ask, have you initiated a deprescribing conversation and information seeking on medication harms? And what they found was, of course, not a lot of people were aware of deprescribing, but many people were aware of harmful medications. And those individuals who were aware of harmful medications did initiate a conversation with their providers. So 2/3 of the population that they surveyed had some awareness of that the prescription medication could be harmful. And of those who were aware, they then initiated a deprescribing conversation with their provider. More women than men were noted to do this, and individuals who were younger than the age of 80 were often more often known to have these conversations with their healthcare provider. What the authors of this study looked at are predictors for initiating deprescribing conversations with the healthcare professionals. The number one for finding was the awareness of medication-induced harm. So if they knew that this medication had certain side effects or long lasting effects, they would have those conversations. They found that, like I said, very few people were aware of the term deprescribing, and there was some concern about the way that that term translated to the French population. There are a couple of words that would translate over for deprescribing, but the authors did mention that as a concern. For those individuals who were aware of the medication harms, they were more aware around proton pump inhibitors, and that may mean that we're doing a better job in discussing the unnecessary need for long-lasting proton pump inhibition. What I thought was interesting is that those individuals who were seeking information on medication harms, of course, had more awareness. And, you know, even though we may not always like the idea of patients searching on the internet, those individuals were more aware of harms for their medications. So the conclusions of this study was that a provider can facilitate a patient-initiated deprescribing conversation by providing information on medication harms, which is something I think we would all think is pretty common, and you know, probably is a point that we all are pretty much in agreement with. But you know, in looking at it, you know, that's still something that I'm wondering, do we do? And so that led me to this paper, which is Physician Perspectives on Deprescribing Cardiovascular Medications for Older Adults. This is by Dr. Goyle, and this study really made me interested. It is also out of the Journal of American Geriatric Society because it is another survey. And many of you may have been actually surveyed. It was 750 physicians per each specialty surveyed, and they had a pretty significant response rate. The reason why I think it stuck out to me is because this is the conversation we're always having about these cardiovascular medications. And as we know, many of the older adults, certain older adults, 80 plus, 90 plus, were not included in a lot of these studies that have come out with a lot of cardiac guidelines. So the purpose of this study was to characterize and compare clinician perspectives regarding deprescribing cardiovascular medications across 3 specialties. So they asked geriatricians, general internists, and cardiologists. And as I stated before, 750 physicians were surveyed from each specialty. The response rate was 26% of the geriatricians responded, 26% of general internists responded, and 12% of cardiologists responded. So they come up, if you just going through the study, there's a couple of pretty interesting graphics. The first is around deprescribing behavior. And this graph represents the percentage of respondents who considered deprescribing cardiovascular medications in the prior month. So just looking at it, you know, pretty much even, you know, there's always some reason to consider deprescribing, or the thought comes into the minds of these physicians who were surveyed. And then they broke down the reasons for that thought. And the majority of the reasons were around adverse reactions. So in general, geriatricians, general internists, and cardiologists were all thinking, okay, there may be there's an adverse reaction, we may need to stop this medication. But as you make your way down this graphic, you know, we see that limited benefit given limited lifespan was something that was more considered like by the geriatricians in this survey. Less so by the general internists, and you know, very few cardiologists thought of this as a significant reason to deprescribe. And it goes down, you know, I think it's interesting, when we're concerned about cognition, more than likely geriatricians are considering deprescribing. What I thought was interesting was around the medication costs. Cardiologists in that, I would say probably the only bucket where they consider deprescribing a medication. They then looked at how often physicians communicate with each other, and the percentage of respondents who discussed deprescribing a cardiovascular medication with another clinician in that prior month. And as you can see, you know, not to toot our own horn, but geriatricians were doing this more often than the general internist and the cardiologist. When we look at the reasons why we're having these discussions, you know, not taking into consideration that did not engage another physician, the majority of those reasons were around major adverse reactions, and amongst the geriatricians, it was around limited benefit given the limited lifespan of that patient. So this is a bit of an eye chart, but I wanted to go through it because in this study, they also gave this, the respondents a hypothetical case scenario. So what that means is that they asked them several questions. If you had a patient with no specific health concerns, would you deprescribe medications? And of those medications, what sort of medication would you deprescribe? And they went on with several other scenarios. So the one that I would point out is the patient expresses desire to decrease the number of pills. We see that 85% of the geriatricians who responded would think about deprescribing in that situation. But we still see a very different number for both the general internist and the cardiologist. And when we go over in this graphic, what medications do we tend to deprescribe given that scenario? You see that for this one case, atorvastatin and aspirin were high on the geriatrician's list, as well as metoprolol, and much lower as we went from the general internist over to the cardiologist. I thought it was also interesting that in the case of an adverse event, recent hospitalization with lightheadedness and a fall, everyone said, oh yeah, we should consider deprescribing. But when we look at the 4 medications asked about, only, you know, you see that there's some discrepancy where the geriatrician is saying, let's discontinue the lisinopril, metoprolol, and possibly the aspirin. And it's much different as you go to the cardiologist, who may definitely has a different perspective on what to discontinue. And we see these discrepancies as we move through these hypothetical scenarios. So they looked at the barriers to deprescribing, and what they found was that the majority of all of us, all of the physicians that they surveyed, found that there was a concern, they had a great concern about interfering with another physician's care plan. So that was the majority of the reasons to not deprescribe, to not initiating a reduction in that medication or a discontinuation of that medication. The other factor that played into effect for the geriatricians and the general internists, more so than the cardiologists, was patient reluctance, which I thought was interesting. You know, it seems that in this bucket, the cardiologist does not weigh in the patient reluctance as much as maybe the geriatrician and the general internist. And then for lack of patient understanding of deprescribing, the geriatrician seemed to have a bigger barrier to that. For cardiologists, where we saw that they had a significant barrier was insufficient evidence of deprescribing benefits. And, you know, I mean, I think that is definitely a point of discussion, because they're looking for more of the scientific reasons to stop a medication, or the outcomes. Are there any outcomes to discontinuing a medication? So a conclusion in this survey, Each physician group frequently considered deprescribing a cardiovascular medication in the setting of an adverse drug reaction. But where there was variability was around other reasons, life expectancy, cognition, all of those other reasons varied. And the shared barrier was amongst each specialty was interfering in another physician's plan of care. After reading this paper, I thought there were some considerations, things that we should take away. And one is the consideration for deprescribing due to adverse drug reactions is common amongst all clinicians. So this is the #1 reason why we would think to stop a drug. But as I just stated, when we're talking about life expectancy, polypharmacy, and other reasons, there's just a considerable amount of variability. So we're all looking for something to help us guide us into determining if we need to or if we should deprescribe a medication, which is why I found this study very interesting. And this is out of the Journal of American Medical Directors Association. It is this deprescribing as a clinical improvement focus. So this is an original study completed by Dr. Rajan, I hope I said his name correctly, and his group, and they were in the Bronx, which is an interesting place to do the study. And what they did was look at, they had a geriatric fellowship, and they had these geriatric fellows practicing in both long-term and outpatient clinical settings, and they determined that they wanted to look at success rates around deprescribing. So the study objectives were to determine deprescribing success rates and relate findings to drug classes and clinical settings, and identify the factors that have influenced the deprescribing process. And this was a performance improvement project with the objective to, let's state it before, demonstrate success for deprescribing. I thought it was interesting that they did this as a PIP, and it really sort of makes us think, okay, what are we looking for? What are the goals of this study? What are the outcomes that we're trying to impact and improve upon? So this is the algorithm that they utilized. In here, I would say to note is the questions: is the medication beneficial to the patient, and is the medication unnecessary? Can it be discontinued? So they followed this algorithm for both their long-term care patients and their outpatient. And they asked, were there any adverse events following deprescribing, which is a pretty good question. It sort of goes back to what the cardiologists from the previous study are asking, where's the evidence that this is a benefit? So this table 1 describes the success rates based on drug class. And, you know, I would say when we're looking at the long-term in the clinic, there are no real big shockers. Proton pump inhibitors, you know, we were successfully able to deprescribe antihistamines. If you were ever my student, my nurse practitioner, or anything, you would know how I feel about antihistamines on a chart in a long-term care setting. And, you know, we also saw some success around analgesics. Where we didn't see as much success were around antipsychotics, anxiolytics, and antidepressants, which we'll talk about in a minute. So they summarized that the factors that render success was a good and solid patient and physician relationship. You know, you needed to have that, and you needed to have a provider who wanted to do it, who was interested in doing it, and would have those conversations and do that education. Factors that impeded the process were if the patient was new, if there was insufficient time, if there was resistance from consultants or other staff, and that other staff was not necessarily another clinical provider. It could be the nurse, the nursing staff, which most commonly the staff issues, the pharmacy. If there was some discrepancy or disagreement, those may be reasons to not discontinue that medication. And then factors that require restitution of the deprescribed medications, if there was a new goal for the care, if there was an adjustment medication that required adjustments, such as adjustments based off of the labs, and if it was a recommendation from a consultant to continue the medication. So the conclusions of this study was that an organized physician effort can help to achieve deprescribing. They also concluded that collaboration with the interdisciplinary team impacted success rates. One other main conclusion that they had was that certain medications such as antipsychotics and sedative hypnotics proved to be more difficult to deprescribe and were commonly restarted. And what they mentioned as a reason for this was either complaints that the patient was having inappropriate behavior, nursing complaints, family complaints. Limitations for this study was that it did not collect information on negative clinical outcomes, and long-term measures of mortality were not studied. But it leads us into a discussion around the practical implications. And, you know, I wanted to leave time to really have this discussion, because when I think of through these papers and about deprescribing as a whole, I keep asking, what are the main challenges that we as a profession are having? Is it unfamiliarity with the medications? Is it lack of collaboration between prescribing providers? You know, this has always been a challenge in the outpatient setting, where you may have a patient who not only is seeing you, but they're seeing a kidney doctor, a cardiologist. Can be a challenge even in the hospital setting. Where we're seeing it as a bigger challenge is in our long-term care setting, where we're having more specialties come into our facilities and practice. So is there a lack of collaboration between those prescribing providers? Is it because of a lack of protocols around deprescribing? You know, this study that we just mentioned talked about an algorithm to start deprescribing, and there have been many other studies and many other conversations around how to start deprescribing, but it still seems to lack uniformity amongst our profession. And then what really struck me in this last paper was the unclear non-pharmacological interventions. You know, if we're going to stop a treatment such as an antipsychotic or sedative, hypnotic medication, anxiolytics, what are the non-pharmacological interventions that we need to start? And I was, you know, in addressing not only some of the findings for that paper, but just as a whole, are we still at the point where we do not have those interventions defined or are adequately addressing in our facilities? So with that, I'm gonna open the discussion, and please take yourself off mute. And any and everyone, please, let's have a discussion around deprescribing.
Hi, Dr. Sanders. This is Dr. Novelli. An excellent discussion as always, and illuminating, but somewhat disappointing in that we're not making as much progress as we would like. But I think that what this really highlights is the tension between deprescribing and compliance, for example, with best practices and society guidelines. Where you may see a subspecialty says you have to be on these 6 medications to optimize your outcome for X or Y condition, and having a difficult discussion about you're approaching perhaps the end of life, and the benefit is starting to not be as much as we would like, and the risks are starting to increase. So those are all very difficult discussions to have. And then you may be sort of saying, perhaps it's time to customize the guideline for an individual and say, how do we alter this? But then you're faced with saying that my cohort of patients is not all utilizing all the medications that are recommended for a given guideline, but because of this other factor where we're trying to deprescribe and look at limitation in lifespan. So I think that there's a substantial tension in that, and we don't have a good process for really looking at that.
I definitely agree. Any other comments?
Do you have a
Yeah.
best sense of how it might be to approach a conversation about deprescribing with an individual who you're considering deprescribing to sort of address all the issues that might come up at that time?
Yeah, and you know, I don't know how I could talk about a couple of experiences I had at a nursing facility. You know, it was a little bit different. I feel like a dinosaur, but back in the day, when you would sit down with the pharmacist or the DON and the administrator and actually go through medication. But the way I always approached it with family members and or patients were to review the medications, and we would have an open conversation, whether it was in my office, the nursing home, the assisted living facility, open conversation about how, you know, how are we feeling, how are we doing, and what can we stop? You know, most times in the nursing facility, you don't have the problem of having patients all 1,001 vitamins and over-the-counter medications and taking different combinations of things that they have that once helped them maybe 5 years ago, that's still in their cupboard. But, you know, when you sit down and we would put all those medications out on the table, if I was in their home or have to bring them into the office, and you go through and say, okay, what are we taking this for? Let's think about it. Let's either think about reducing this medication because of the way they're feeling, or that the fact that, you know, I have a cholesterol level that's been stable, or you're in your 80s, or you're in your 90s. Let's stop. We can stop this medication. Or, you know, in the case of those adverse reactions, if I'm worried more about the person's blood pressure being normal and I have someone who's hypotensive, I may say, let's go through and look at the blood pressure medications we can stop. You know, I will say the tougher conversations were around when the proton pump inhibitor started. I guess it became in vogue to stop them. We got a lot of new science and new data, and having those conversations, there were a lot of people who wanted to hold on to that proton pump inhibitor for dear life. But, you know, saying we can reduce the dose and let's see how you feel off of it, and let's go to H2 blocker if we still have symptoms. Those are probably the more challenging conversations around this. Usually it has been more of a challenge with someone, and I would definitely admit to what they found in the JAMDA paper, with someone who you've never met before, because they're trusting what the last physician who prescribed all these medications are on. But that's only been my experience, and I would love to hear about anyone else's experience in the day-to-day practice.
I'm Dr. Sanders-Cepeda. So in my outpatient practice, generally I'm not going to try deprescribing too many medication in one visit. But in that place, I will try to find out what are the high risk medication patients is on, and then I will ask them how much benefit those medications are giving them, and then I go to up to date and put the drug's name and I show them the adverse reaction, and then they tell me, oh, I have this problem, I have this. That gives very easily, you can convince your patient that a certain medication is not good for them. So if we do the stepwise approach and we show them the evidence that this medication, sometimes I'm saying whomsoever has a Parkinson's disease and have tremors, they are on 2 or 3 tremor medications, and we see they have tremors. So when you go and talk to them and one by one you try to taper down, and they say, oh, I have not got worse my tremors after stopping one medication then another. So in that way, if we do stepwise approach, I think we have more success in that, and I have very good success in my clinic patients.
Oh, thank you for that. Those are a good point. Like addressing it, looking at it, and doing a stepwise approach, sort of in that algorithm that they showed in the study. You know, it does have success. I think where I am concerned and worried about is around certain medications like the antipsychotics and some of the cardiovascular meds. I think we, amongst us, probably on the phone and in our societies overall, we know that there are significant issues with some of the lipid-lowering medications, and there may be issues around the beta blockers and other antihypertensives. I was surprised in the study where there was a lot of resistance around antipsychotics, even given all of the latest push to individualized dementia care. I know in my experience with working in the state of Florida, not only in a nursing facility, but with more than 100 nurse practitioners scattered across the state, you had to make an effort to have a conversation, and we also had to figure out what we were going to put in place as an intervention for that person. You know, so I was a little alarmed that we were still there for the antipsychotics and the anxiolytics. I think with every medication, we should take that stepwise approach that you spoke of and look at, okay, what is the medication being used for? What is, how are you feeling on the medication? What are the side effects? And let's have the conversation about, do we need this medication any longer? So if there are no more comments, I want to say thank you for your participation. And I hope you guys enjoyed us for our March Journal Club coming soon. We're going to talk about impacting hospital readmission. Thank you.